Hi, this is Dr. Tim Kosinski. We're going to start in a few minutes in our webinar tonight, Proven Clinical Steps to Achieve the Ideal Implant Foundation. We'll be starting in just a few minutes. Get everybody signed on. We'll have an enjoyable hour together. We're just going to take a few minutes to let everybody get signed on tonight, and we'll get started. This is Tim Kosinski, and we're almost ready to start our webinar tonight, Proven Clinical Steps to Achieve the Ideal Implant Foundation. Another minute or so, we're going to start our webinar tonight, giving a few more people a chance to sign in. Welcome, everybody. We're going to give it another minute, 30 seconds to start our webinar on proven clinical steps to achieve the ideal implant foundation. We have a big treat tonight. Dr. Jack Hahn, the creator of the original tapered implant, replace implant, will join us a little bit later during the program. Very excited about that. So we'll give it another 20 seconds or so and we'll get started. Looks like we have a nice audience tonight. Hopefully we'll be able to show some innovative things that you'll be able to use in your practice. So it's a little bit after 8 o'clock Eastern time, and I think it's appropriate to respect everybody's time. We have a good group, and let's begin our webinar tonight. I'm Tim Kosinski, and our topic today is proven clinical steps to achieve the ideal implant foundation. And what that means is we're going to demonstrate some of the techniques that I use to create a foundation, a basis, so to speak, for our implant dentistry. Some of you know me as have seen some of my articles. We've published quite a bit. We place a lot of dental implants. We're here in the Detroit area, and I'm proud to say that we're associated with Golden Dental Solutions tonight and showing some of their innovative techniques and products. And a little bit later during the program today, we're going to have a dear friend of mine, Dr. Jack Hahn. I've known Jack my entire career, and I respect him as a personal friend and colleague, and also a brilliant mind in implant dentistry. He created the replace implant many years ago, the tapered implant, and is now involved in the creation of the Hahn implant. What an appropriate product for Jack, and we'll demonstrate some of that technique, and then Jack will have an opportunity to talk about this innovative implant. So our objectives tonight are going to be really clear and concise. We're going to demonstrate some predictable and proven pre-implant, quote-unquote, protocol to ensure the proper foundation for dental implants. This will include predictable atraumatic extraction techniques, predictable socket preservation and grafting techniques, and all of us out there who are placing implants or contemplating doing surgical implant placement need to be involved in understanding atraumatic extraction, maintaining the bone quality and quantity, and also making it atraumatic for us as doctors and for our patients. And to do that, we have to have predictable socket preservation and grafting techniques. And so we're going to demonstrate some of the things that I do as foundation for the innovative Hahn implant that I've incorporated into my practice. We're going to give you both clinical and some scientific information on different grafting materials. We'll talk about that and hopefully stimulate you into getting as much education as you can on these different products. And finally, we're going to demonstrate some easy step-by-step instructions on how to immediately implement predictable extraction and grafting techniques into your practice. So hopefully you're as excited as I am today about moving forward. This is not intended to be a dental technique implant program per se, but rather how I try to create a foundation of bone quality and quantity for my patients. All of us out there, for those people who don't place a lot of implants, who want to learn it, you have some fears about placing implants. You're afraid of anatomy. We're afraid of the nerve. We're afraid of the sinus. We're afraid of losing facial plate of bone. And hopefully some of the techniques that we're going to demonstrate today will alleviate some of your concerns. We're going to show some cases from start to finish. Again, this isn't intended to be an implant education per se, but Dr. Hahn was kind enough to join our webinar tonight, and it's quite a treat for me. And I wanted to show you some of the innovative applications of this very, very high quality implant, the Hahn dental implant. So we'll keep moving forward. We're going to talk to some of the products that I use. And I like to say in my lectures, for any of you who have heard me before, is there's a lot of products out there. There's a lot of ways of doing the same procedure. But what I want to demonstrate tonight is what works for me, what works day in and day out for me. So if you do have questions afterwards, I'm going to try to steer you into the products and materials and techniques that I use in my practice. We're going to show you extraction techniques using the innovative Golden Physics Forceps. And at the end of our program tonight, Kurt Lawler from Golden Dental will take some questions, and I'll stay on board, and Dr. Hahn will stay on board to answer some of your questions or answer some of your questions. And also, he will have some specials for you to help you incorporate some of the products that I use in my practice. We'll talk about different grafting materials, and again, the materials that I use are purchased from Golden Dental. I think it's important that when we're grafting cases, oftentimes, well, insurance company, dental insurance just doesn't cover our grafting procedures. So making it cost effective for us makes it cost effective for our patients. So we can demonstrate some of that tonight, and maybe Kurt can answer some of those questions. We're specifically going to demonstrate the Hahn dental implant, which is available through Golden Dental, through Glidewell Lab, excuse me. And so I'm very, very excited. We've placed probably over 1,000 Hahn implants to date, and I'm very excited and very happy with the results. So the final result is the most important thing, and we want to be predictable. And I think that's a word that I use a lot in my teaching, is we really want our final cases to be predictable. So if I can demonstrate some cases that if you follow step by step, will give you the same predictable results that I receive every day. And we know that as dentists, things are changing so fast, and being open to learning new techniques is important. And I respect you for taking an hour and 20 minutes with me tonight to learn some of these techniques. I'm very excited about it. So what can contribute to implants not being successful? Well, there's a lot of stuff going on. Traumatic tooth extraction, losing bone. We know that bone is gold to me, and I like to maintain the facial plate of bone whenever possible. So if I'm able to use extraction techniques that allow me to maintain all four walls of bone is very important, because if I'm able to do that, I basically have a cereal bowl or a waffle cone to speak of. And I can very, very predictably graft that site and immediately place implants. Dr. Hahn demonstrates that all the time in his clinical demonstrations. And I love to be able to immediately place an implant whenever possible for the patient. We limit the number of surgeries the patients have, and the patients are very responsive to this. However, the most important thing is that we get a positive result, that our implants integrate, that our bone changes over. We all have had issues with extracting teeth. from my early days to your working days now, removing teeth can be traumatic, and many of you out there just don't remove teeth. We refer it out, or we don't feel very comfortable doing it. And with the Golden Dental Physics Forceps, I'm able to very routinely remove teeth atraumatically to the bone, atraumatically to me. I don't sweat under my armpits and get all nervous about an extraction. And probably most importantly, that we're able to remove teeth atraumatically to the patient and give the patient a positive experience. It's important that you understand the different graft materials that we have and how they resorb and how they turn over. We all know as dentists that bone is alive in the body. It's constantly changing over. So we have situations where osteoclasts will eat away whatever material we have in a grafted site, and osteoblasts will lay down new bone. So no matter what we put in a socket, it will change over into natural bone. When we have grafting material, we have to protect that grafting material from invagination of epithelium, and so we will use a membrane, and I'll demonstrate how to use that. Maintaining soft tissue. I'm going to show you some of the envelope flap techniques that we use. Obviously, we can't show you every technique that we have in this one webinar, but we'll try to do our best to demonstrate the most effective ones. And maintaining bone height and width and quality is very, very important in maintaining bone and preventing or minimizing future bone loss. So let's look at extraction instruments. An ideal tooth extraction is defined as the painless removal of the whole tooth or root with minimal trauma to the investing tissue so that the wound heals without compromise and no postoperative prosthetic problem is created. This is especially true in the anterior area, in the aesthetic zone, where we want to maintain interseptal bone, thus maintaining inner dental papilla. Conventionally, we have a lot of forceps out there. We all have trays and trays of different forceps. And why is that? Well, we go to meetings, we talk to friends and colleagues, or we've had problems removing teeth conventionally in the past. So we purchase different types of instruments, different sizes to help us remove teeth atraumatically. We have elevators and periotomes and luxators, different types of forceps to remove teeth in a predictable manner. But these techniques are not necessarily always predictable. Using the Golden Physics Forceps allows me to prevent things like this, where with a conventional forceps we're grabbing onto the facial and palatal aspect of a tooth, squeezing the heck out of that tooth, using figure-8 motions, buccolingual, and boom, what happens? The facial plate of bone cracks, or worse, a root tip occurs. And then we end up spending a lot of time trying to remove a root tip. So conventional techniques may be predictable sometimes for you, sometimes not, but there really hasn't been any real advancements in most of these instruments for over 100 years. We have to learn to predictably extract teeth, and we want you to learn a technique that I would not practice without, and that's using the Golden Physics Forceps. I don't think a day goes by that we don't use the Physics Forceps. And for those of you who are interested, we have a lot of YouTube videos on the techniques. We do have courses at our University of Detroit Mercy School of Dentistry, but Kurt can demonstrate some of that information to you later. This is what Dr. Hahn and I use. We use something called the Golden Physics Forceps, which has two components to it. It has a beak, which is like a shovel-shaped edge, which will engage the palatal or lingual aspect of a tooth, 1 to 3 millimeters subgingival. That is the working end of the instrument. That is the part of the instrument that will create tension onto the periodontal ligament. Tension of the periodontal ligament will cause an enzymatic physiologic reaction in the body, which will destroy the periodontal ligament. Without the periodontal ligament being intact, the tooth will come up and out of the socket. The second part of the instrument is referred to as a bumper. And that's a part that is placed as high up or as low into the vestibule as possible and simply acts as a fulcrum. It is not the working end of the instrument. Rather, it allows us to create tension onto the palatal or lingual aspect of the tooth, allowing that tooth to be lifted up and out of the socket. And we'll demonstrate some of that in a little bit. Kurt can go over this a little bit later at the end, but the standard set of physics forceps simply consists of 4 instruments: a maxillary right, a maxillary anterior, a maxillary left, and a universal lower. This is my favorite set of instruments, and we're able to remove the vast majority of teeth with one of these 4 instruments. There is a second set of instruments which are referred to as the Molar series, which allow us access to teeth that we're not able to remove with the conventional physics forceps. It allows us to engage the facial or lingual or palatal aspect of a tooth and thus remove the tooth towards the outside of the mouth or even intraorally, and with the same type of motion, creating tension and breakdown of the periodontal ligament. I know everybody wants to see clinical cases, so let's get right into it. Let's look at a single extraction. Here our patient presents with a tooth that needs to be removed. It was deemed non-restorable. We have a fracture in this tooth. But what I most want you to see in this clinical demonstration is the interdental papilla. Obviously, the attached gingiva is not healthy in this area, yet we have the triangular tissue, the interdental papilla, intact. That is very, very important in the aesthetic zone. If any of you have family members or loved ones that unfortunately have to lose a front tooth, or maybe some of you out there have lost a front tooth, maintaining the bone in that area is critical to achieving the best aesthetic result that we possibly can. And Dr. Hahn will tell you that restoring our implants with emergence profile is an important part of dentistry today. No longer do we just place implants in bone, rather we want to establish the greatest amount of aesthetics that's possible. So we have a tooth. Again, look at the interdental papilla. That interdental papilla is maintained by interseptal bone. Without interseptal bone, the interdental papilla will blunt and cause an aesthetic problem for us. So being able to remove this tooth without damaging the facial plate of bone, without damaging the interseptal bone, is very important. So here you can see that we have an infected area, and we are simply going to use our physics forceps. Again, the physics forceps has 2 components. The beak, which will engage in this situation the palatal aspect of the root, 1 to 3 millimeters subgingival. The bumper, which simply acts as a fulcrum, rather a center of rotation. You can see how unique this instrument is shaped. It's shaped in a semicircle, and thus allows the tooth to be removed along the axis of that semicircle. A bumper guard is simply a silicone attachment. We throw these away when we're done with them. That allows a little cushion. Now, some of you may have seen or heard about this forceps and said, well, I get bruising of the facial aspect. What's unique about this instrument is there's no squeezing of the handles. We're simply creating tension onto that palatal aspect of the root. We are not squeezing the instrument. So theoretically, if used correctly, the tooth will lift up and out of the socket, and we will not be able to damage the facial plate of bone nor damage the soft tissue on the facial aspect. So this silicone attachment will be placed onto the bumper, and this is our instrument. And we'll simply go to the site. We'll engage the palatal aspect on the root structure. The bumper goes as high up the vestibule as possible. Now please, we do not squeeze this instrument. We are simply holding the handles firmly and rotating our wrist. I am rotating my wrist towards the nostril in this situation. So thus, in that rotation of the wrist, there's no forearm, there's no bicep, there's no shoulder pressure whatsoever. We are placing tension onto the palatal aspect of this root, thus allowing the tooth the periodontal ligament to be destroyed by enzymatic action, thus releasing the tooth. You can see I'm holding the handles firmly, but I'm not squeezing. I'm simply rotating my wrist, and in a matter of seconds, maybe a minute and a half, you'll see that the tooth starts to move and will pop. Now you're not going to hear a pop, rather the periodontal ligament will be destroyed and the tooth will disengage. Now, some will take a luxator or an elevator and try to luxate the tooth or take a osteotome and go into the periodontal ligament area. I normally don't do that. I normally go right to the instrument to remove the tooth. The tooth disengages 1 to 3 millimeters. The instrument is not intended to remove the tooth in total. Rather, it's intended to luxate the tooth and loosen it. I will then take what we refer to as a tooth delivery instrument, simply designed forceps. I will grab onto the tooth and simply rotate. And because the periodontal ligament is destroyed, the tooth will come up and out of the socket. Very important slide here, everybody who's listening. Very, very important slide. The interseptal bone is maintained. The facial plate of bone is maintained. Thus, the interdental papilla is maintained. We were able to remove this tooth that had a vertical fracture in it quite efficiently in a matter of a couple minutes, maintaining the bone. We now have a socket. We have a waffle cone, a cereal bowl. At this point, we can elect to graft the site. We'll demonstrate that in a little bit. Allow it to heal and come back and place an implant ideally. Or for those of you who are a little more experienced, we could immediately place an implant in the site. Lower molars, tough teeth to remove? Can be. Tooth is deemed non-restorable, has a crown, and we're going to remove this tooth using the physics forceps. Now, the problem with removing mandibular molar teeth is the roots are often divergent, and the bone is very, very hard. It's cortical bone. So in these situations, I like to section the roots and remove the mesial and distal roots as if they were single-rooted bicuspid teeth. It makes it very efficient and nice. But to do that, I first have to remove the crown. And to do this, if you've never seen this before, I strongly urge you to talk to Kurt at the end and order these products. They're called a WAM key. And a WAM key is a series of 3 instruments that have a little ball on the end. Conventionally, to remove this crown, I assume most of you would take a burr and cut the crown off from facial to lingual, take some type of instrument and separate it and take the tooth out. You go through burrs, it takes a lot of time. In this situation, using the WAM key, I will simply make a small occlusal facial hole into the crown, through the crown to the central groove area. Now, the question you may have is, well, how do I know where to make that hole? Well, you have to assume, obviously, when we take an x-ray, we don't know where the preparation is. But I'm assuming that the preparation is 2/3 up the crown, meaning we have 1/3 of the occlusal surface of that crown, which is metal, zirconia, and a porcelain. So I'm simply guesstimating where that tooth is, where the preparation, occlusal preparation is. So I'm simply making an opening. I'm taking my WAM key, and with a simple twist of my wrist, that tooth will come off. Now, in this situation, I'm going to remove this tooth. But in some situations, we remove crowns and we replace them. And what better temporary restoration would you have than this? You can then reline this or put a little composite in that facial hole, and the patient would have a very, very nice temporary. This is very nice. As zirconia crowns, Bruxer crowns become more popular, for those of us who have tried to remove Bruxer crowns, it can be a real challenge. You're going through very expensive fine diamond burrs, and it can be a very time-consuming process. Well, if you simply take a fine diamond round burr, you can make a small opening through that zirconia crown and use the same technique and remove the crown in total in a matter of a couple minutes. Now, here we have a tooth that is non-restorable, and as I said, removing a fractured molar teeth with divergent roots can be challenging. So I'm simply going to section the roots mesial and distally, and this video shows that it's very important that you use your radiographs to determine correct sectioning. Here, we didn't section through the furcation, and thus the tooth is still in one piece. It's going to be a challenge to remove. So I think it's important that you realize that you have to section through the furcation, separating the roots. So basically they are two separate roots, single-rooted bicuspid roots, so to speak. I can then take my physics forceps very predictably, without any pressure, with very, very little pressure, very atraumatic to the patient, and amaze the patient with the final result. So here I'm taking a 557 long surgical burr, sectioning, making sure I'm through, and then I'm taking my physics forceps. Here I'm using the universal mandibular forceps. I'm engaging the lingual aspect, 1 to 3 millimeters subgingival, placing the bumper as deep into the vestibule as possible, and simply rotating my wrist. I am not squeezing. There's no forearm. There's no bicep. There's no shoulder pressure whatsoever. I'm simply rotating my wrist towards the shoulder, and in a matter of a minute or so, that root will come up and out of the socket, and I will have a nice four-walled socket to deal with. In these situations, I will graft this site with one of the materials we'll demonstrate in a few minutes, allow it to heal, and then I can very predictably place an implant. It will prevent bone loss, and it will maximize the amount of bone I have for my eventual Hahn implant. So here we take our tooth delivery instrument and remove the roots in total. So we have a nice socket. Full mouth extractions. We have a tooth that is grossly decayed, in periodontally involved teeth to some degree, and removing this tooth can be a challenge for some of us. But again, with the physics forceps, you have to have a purchase point so that the beak can engage the lingual or palatal aspect. So if you don't have a purchase point, I'll simply take a burr and flatten the lingual aspect of the tooth so that I can get a purchase point with my beak, and again, using the rotation technique, allow the periodontal ligament to break down, allowing the tooth to come up and out of the socket, maintaining that facial plate of bone, allowing me to have a socket with all four walls intact. This is a very, very atraumatic, I know I've used that word several times tonight, way of removing a tooth. Atraumatic to the bone, atraumatic to the doctor, and atraumatic to the patient. Our patients are immensely impressed. I can't tell you how many times they go, you're kidding, you're done? Wow, I never felt that. It was wonderful. So here we're just using our surgical burr, and I'm flattening the root structure. I'm trying not to remove bone, rather flattening the root so that I can have a purchase point. I'm then taking my physics forceps, engaging the beak, placing the bumper as far down the vestibule as possible, and not squeezing the instrument, simply rotating towards the shoulder, and you can see the tooth will pop. It comes up and out of the socket. The instrument is not intended to remove the tooth in total. Rather, we'll take a tooth delivery instrument and remove the tooth. So we have these socket sites achieved through an atraumatic extraction. What do we do now? Well, we want to demonstrate some of the grafting techniques that we use. Again, I'm going to show you the products that I use that work effectively in my hands. They're very predictable. There's nothing magic here, doctors. It's something that all of you can do, but there's no shortcuts. We have to be very precise and accurate. We've already talked about the walls. When we're able to keep all the walls intact, it makes grafting fairly routine. The only difficulty is that we have to protect the grafted material from invagination of epithelium, which grows dramatically faster than bone. We all know that a socket heals from the apex towards the crest, so we want to protect that crestal graft material from invagination of epithelium. The worst scenario in our case, as a general dentist, is if the facial or buccal wall is damaged. And I am telling you that we can repair those one wall defects, or defects where three walls are intact and the facial wall is gone, very predictably, as long as we know how to use our membranes to protect the grafted material. And I'll demonstrate that in a few minutes. So why do we socket graft? Gordon Christensen, my friend, will certainly tell you that grafting is an important part of dentistry today. If you're removing teeth and you don't graft, you're going to get bone shrinkage. Bone is going to shrink down and in or up and in, which can create challenges for implant dentistry or even conventional dentistry or partial frameworks, removable construction in the future. And repairing those defects in the future can be very traumatic and very expensive to the patient. So I think you owe it to your patients to explain the benefits of maintaining bone to the best of your ability. We're trying to prevent future bone loss. We're trying to support adjacent teeth. We're planning for future options such as implants or even fixed bridges. We all have seen cases where the facial wall has such a defect that we have a large concavity, and that can result in a food trap or a poor aesthetic result. We like to say it's much easier and less expensive to preserve bone now rather than try to create bone later. And as general dentists, I think if you have that approach, you're going to be very successful in treating your patients. And I think the patients, when well educated, understand the benefits of this process. If you don't, we may need additional surgeries. Oftentimes we'll do autogenous grafts where we'll take bone from the symphysis or ramus and put bone screws to try to reestablish bone height and width. Tough surgeries on a patient and expensive surgeries for the patient. These procedures that I'm going to demonstrate are simple, safe, and very effective. And we all know that we can prepare for the future because our patient's financial situation can change over time. So very briefly, I don't have a lot of time to go into this in great detail, but basically there's 4 types of augmentation products, and I'm going to just demonstrate the ones that I use in a few seconds. Autogenous bone is the gold standard. That's the patient's own bone. Again, we can harvest that from the ramus, from the symphysis. We can harvest it from socket sites in our osteotomies, in implant placement. An allograft is bone from another species. From our species, human bone. An allograft is cadaver bone or human bone, that's harvested from the same species. Now, there was a time when allograft was a little bit difficult, a little challenging for us to describe to our patients because of some of the issues that were involved with the health of the product. Now, however, our allograft materials are very safe and effective and very well controlled. There are different types of allograft materials. There is cortical, which is made from the hard cortex of the bone, medullary bone or cancellous bone, and bone can be mineralized or demineralized, and that just is a term on how it's processed. But human bone allograft material is an outstanding grafting material when protected. Xenograft is bone from another species, cow, pig, horse. I'm not a big user of xenograft materials, so I'm not really going to talk too much about it today. I'm not criticizing what other people have done, but in my hands, it has not been my graft of choice. Alloplastic material are synthetic materials. One such product is tricalcium phosphate. Another are calcium and phosphorus particles in different types of matrices. Alloplastic materials are made in a laboratory, and they are very safe and effective, and I find that they're very easy to discuss with my patients. When we remove a tooth, I tell them that it's imperative that we fill that socket with something or the bone will shrink, making our future dentistry more difficult or challenging. Some of my patients, for a number of reasons, maybe religious, prefer not to have allograft or bone from another human. And so when I tell them that we're using a product that was made in a laboratory, assault, so to speak, it becomes very, very well accepted by my patients. So let's keep it simple. There's a lot of stuff out there. As I said, allograft is human. You can have mineralized cortical and cancellous. You can have one or both. I like the combination, and I like the combination because the resorption rates are different. So cancellous bone resorbs faster than cortical bone. but I want the final quality of bone to be ideal. Remember, when you're talking to your patients, anything that we put into that area is going to be resorbed away and replaced with the patient's own bone. You break your arm, you're in a cast for 6 weeks, that wound will heal. Golden dental solution, and again, Kurt can demonstrate some of this later. We have a crunch putty, which has cortical particles in it. We have particulate that you can mix with sterile saline or sterile water. Great products. Alloplast that I use, tricalcium phosphate. I like the Ceresort product from Curasan. And another great product that we've been using for the last year or so is a product called Osteogen Plugs. Again, available through Golden Dental Solution. It is a calcium and phosphorus particles that are non-sintered, meaning they're not melted together, in a bovine Achilles matrix. And very, very convenient. I'll demonstrate one of these cases in a few minutes. The membrane that I'm going to discuss today is called EpiGuide. It's a resorbable membrane that is very specially created. It's trilaminar, and it has about an 8-week resorption rate, which makes it a very, very effective membrane to use short-term and long-term. Almost acts like a non-resorbable membrane in a lot of situations. So you have to know your products. You have to know what you want, when you want to use it. You have to know the cost. But again, I'm using Allograph and alloplastic materials from Golden Dental Solutions, and I really like the EpiGuide resorbable membrane from Curasan because I know the results are consistent. I know that I can grow bone, I can grow a wall, a missing wall, very effectively with the products that I'm going to demonstrate today. So let's go through another clinical case. Here we're going to do an atraumatic extraction. All the walls are intact. We can use an Osteogen plug in this situation. And again, we have a tooth that is deemed non-restorable. I think we all agree that this tooth is non-restorable. The patient's in pain, the patient comes in, and we want to remove this tooth. So how do we do this, doctors? What's the best way to remove this tooth? You can see the older implant crown in the back that was done somewhere. And we want to remove this tooth without damaging the adjacent implant or crown and the adjacent worn teeth. So I'm going to use the technique that I demonstrated earlier. We're going to make a purchase point, place our beak onto the lingual aspect, put the bumper as far down the vestibule as possible, and you can see in this situation they have a very shallow vestibule. Rotate my wrist towards the shoulder. In a matter of a minute or so, this tooth will pop. We'll take my tooth delivery instrument and remove the tooth in total. I'm going to curette the socket. I'm going to remove any granulation tissue, any purple blood. Red blood is great, purple blood is bad. So curette the socket. And this is what the Osteogen plug looks like. It almost looks like a piece of chalk. It is malleable to some degree, and it can be cut. There's two sizes, a thick and a skinnier one. And I'm simply taking this product to the site and I'm pushing. And what's unique about this product, as it absorbs blood, it takes the shape of the socket itself. Wonderful product. And here I'm just placing it to the crestal height, and I'm going to suture it. Now, you can see I did not put a membrane. And what's unique about this product is because of the compilation of it and because of the matrix, I don't need a membrane. The epithelium will not grow into it, so to speak. It'll grow over the top of it. A very, very special product. This is what the socket site looks like immediately after placement. You can see it's radio opaque. But over a period of time, in 4 months or so, you can see how that socket starts to heal. It heals from the apex. It goes to the apex, and it's starting to heal up to the crest. We have good epithelium. And again, this is not an implant course per se, but we're going to make our osteotomy site using the Hahn tapered burrs. You can see we're harvesting blood, and I actually did histologic evaluations of this material, and we do have bone formation in this plug. Remember, anything we put in there is replaced by the patient's own blood. We're idealizing the placement using the osteotomy burr. And this is the design of the implant that Dr. Hahn can discuss in a few moments. It has a very aggressive threads. We're threading it into the socket. And here we've torqued our implant in at 45 Newton centimeters on a site that had been grafted very, very predictably. Immediate placement, flapless placement. There's very little bleeding. All of you out there can do this type of procedures. Your patients want you to do these type of procedures for them. So I challenge you to get involved, to learn techniques in extraction and grafting and eventually implants. For those of you who are not placing implants, we have some wonderful courses that Kurt can describe to you a little bit later. The implant is placed, the healing abutment is placed, and we can restore that in the future. So I think we can all agree you can do this, and it's probably the most basic grafting techniques, better than doing nothing. Here, let's look at a case where we're missing the facial wall. And some of you should say, well, this is tough. You know, we lose that facial wall, I get nervous. We have a tooth that is non-restorable. We have a distal defect in the bone. So again, my techniques are identical. We're going to remove this tooth atraumatically, trying to maintain as much bone as possible using my physics forceps, not squeezing the instrument. The tooth pops. I'm taking my tooth delivery instrument and I'm trying to maintain the contours of that bone and facial form as much as possible. We have a defect. I'm curetting, and look what we have. We obviously have a facial defect in that area. Now, all of you out here, you can't ignore this. And this is not a situation for an osteogen plug. I don't want to simplify what we're doing too much. Here, you must flap this tissue and you must see the defect in total. And we can graft it, we can put an implant in, but we have to place a membrane, we'll use the EpiGuide, and cover that area and protect our grafted site. If you do not, you will not get healing, and you'll get improper healing, and you'll get a defect. So here we're simply going to take our particulate allograft material, mix it, pre-cut our EpiGuide material. I like to soak it in saline, and here I'm taking an Orban knife, and I'm simply making a very simple incision. We call this an envelope flap. I'm not making any vertical incisions whatsoever. And I'm simply elevating the tissue so that I can see the defect in total. See the defect in total. I feel comfortable immediately placing implants, and we're able to strategically create our osteotomy site, harvesting bone, and I'm going to thread my implant into position. Now, important, look at this implant. The facial area of the implant is completely exposed. I am perfectly comfortable fixing this with our allograft material in a membrane. So we're placing our cover screw onto our implant, and here we're taking our EpiGuide, and I am placing it past the defect, at least 2 millimeters past the defect. If you're going to take one thing out of this webinar, this is critical. When you're grafting a defected area, you must place a membrane, and that membrane must extend at least 2 millimeters past the defect, whatever that defect may be. So you can see my membrane is in place. I'm taking my allograft material, covering it, tucking the membrane over to the palatal aspect, again, tucking it. This membrane isn't going to go anywhere. It's going to maintain itself in position. I'll simply take some sutures and suture it into position, and we will allow this site to heal for about 4 months. Immediate x-ray, you can see the grafted site where the defect was. Here we've had a little flipper appliance, and you can see how the tissue starts to heal over a period of time. Again, losing bone, we're going to use, again, a membrane. We have a difficult area. I don't know if any of you out there have used the Vibroject. Again, Kurt can describe this. It's available through Golden Dental Solution. It's a small vibrator that is attached to your existing syringes, and it actually vibrates the needle. Motor goes faster to the brain than pain, and it's similar to us shaking the lip. We try to distract. And I'm going to honestly say that about 80% of my patients notice a dramatic decrease in the amount of discomfort of that initial penetration of the needle. My staff loves this. This is in every room and placed on every syringe when I do an injection. So again, another tool that's inexpensive that will make your patients more comfortable. So we have a tooth that is non-restorable with a fracture. Again, we're going to remove the tooth using our golden physics forceps, maintaining the interseptal bone in an interdental papilla as much as possible. I'm going to make my envelope incision using the Orban knife. And I want to demonstrate here we have facial plate of bone, but a little bit of a defect where we had a fistula. Again, I'm cutting my membrane to size, placing that membrane past the defect. My allograft material is then placed into the socket, and the membrane covers over it. We'll suture it into position. We'll allow it to heal. The patient wore a flipper for a time, and 2 weeks later, we remove the sutures. You can see some of the excess particles escape. That's normal. After several months, the grafted site is now ready for a dental implant. We maintain some semblance of interdental papilla because we were able to maintain the interseptal bone. You can see we're going to try to get as good an aesthetics as we can. We're going to, here's our little flipper appliance, or our final crown with our implant in position. When we have all four walls intact, there's a lot of products that we can use. We have a tooth that was, again, a vertical fracture of a cuspid. Difficult tooth to remove, yes. Very thin facial plate of bone. I hear all the time that, well, you know, you break the facial plate of bone on cuspids. You don't have to when you use the instrument correctly. Here we use the Defect CBCT analysis, and you can clearly see that the facial plate of bone is very thin in this area. Again, we're going to numb the area, use our physics forceps. The tooth will pop. I'm going to take my tooth delivery instrument and we remove this long cuspid tooth very, very routinely. For education, I took another Defect CBCT and demonstrating that the facial plate of bone is indeed intact. And we can graft this site, and I made a flap here so I could show you that the wall is intact. You can use a membrane or not. Here we're using the putty, and I'm going to thread my implant right into that socket, suture it closed. Post-operative CBCT analysis shows that the implant is placed not into the socket but palatal to the socket and is grafted. It's allowed to heal. The implant is uncovered, and we're able to get a fairly decent final crown on a referred case. Obviously, the patient has some medical issues and some inflammation of the soft tissue. So when we have all four walls intact, you have choices. You can use tricalcium phosphate, you can use Allograph, you can use an Allograph putty, or you can use the Osteogen plug. When you have the facial wall missing, I prefer that you use an allograft or tricalcium phosphate, but you must protect that graft material from invagination of epithelium with a membrane. So at this point, it gives me great pleasure to introduce Dr. Jack Hahn. As I said, I've known Jack my entire career. He's been a gentleman and a friend to me for over 30 years. Very well respected in dentistry and in the implant community, creator of the Replace implant and now the Hahn implant, which is becoming very, very popular. And I'd like to let Jack take over and describe his implant and some of his techniques.
Good evening, Tim. You did a great job in explaining extractions and the grafting. You know, I'll tell you a story about the forceps. When I first saw those, I was at a Chicago midwinter meeting, and I'm walking by this table, and I see these implements, these instruments, like I've never seen before. And a gentleman was sitting there. It turns out it was Dr. Richard Golden. I said, "What are these?" And he said, "They're extraction instruments." I said, extraction instruments, they don't look like the ones I know. And he said, where are you staying? And I said, the Hyatt. And he said, I'll meet you at the bar at 5 o'clock, and I'll show you. And this has got to be over 10 years ago. And he came, he had a model, it was real dark. We had candles, and he demonstrated on the model and had me doing it. And I've been using those ever since. Next, the next slide, please. And so anyhow, let's get back to what we're talking about for this evening, and talking about planning and implant positioning. You have to remember that patients really don't know what implants are. They're a way to give them teeth, and they have high expectations, high aesthetic demands, and it's up to us to put these implants in the most optimum position. It's going to give them the best aesthetic result as well as function, of course. That's why we're doing this. So we use an instrument, again, that's been developed by the folks at Golden, called the MD Guide. And as we know, it's very important in implant spacing. We generally want to be 2 millimeters between the natural tooth and the implant, and 3 millimeters between implants, because we need to have bone between those implants. And when the bone needs to have blood supply. If we put them too close, then we strangle the blood supply. So one of the solutions, and we're not going to be using a laboratory-generated surgical guide, I call this the working man's surgical guide, where we can plan the case right on the patient as you're placing the implant. So you have something, as you see in the upper part of this picture, a twist drill that fits in a handpiece, and you can check it, take it to the ridge, and look at it and see if this is what you want. The diameter is about the diameter of the crown, so you know the end result before you actually enter into the tissue in the bone. So you see the various diameters and sizes has to do with the diameter of the crown. Next. So again, here's the demonstration. You see the photo on the right side. The diameter of the guide is the diameter of the finished crown. So again, it helps you plan your case so you are giving, putting the implant in the most optimum position, not only for the cosmetic and function to the opposing dentition. Next. So here's an example of the first one. We're going to be putting in 2 implants, replacing 2 molars, number 18 and 19. Next. So you see the first, we enter in, the end of this is like a 2 millimeter twist drill. And then these are the guides. You then can place this in there and check it. You see in between the spacing, and you see the space between the natural tooth and what the implant is, where the implant's going to be placed. Next. So you enter in with the first drill, and again, you can take a radiograph, check your position, check your angle as well. You have, those of you that are just beginning in implant dentistry, you have wonderful teachers out there, and Dr. Kosinski is a perfect example. He does many courses for GPs, great courses to jump into the pool and get started. When we started, we didn't have the opportunity to have experienced people. People like Dr. Kosinski, who's placed thousands of implants. And as we know, experience, there's no substitute. Next. So we see the 2 positions for the 2 implants. And again, it's going to be positioned so we have the optimum spacing and that the crowns are going to look like teeth. Next. So there's the implants have been placed. We used a flapless technique. Indications for that are wide enough ridges, keratinized tissue, and there's no surprises, no severe undercuts. Next. So again, we see the implants are lined up in good position to the opposing dentition. Next. And then we have the implants placed, and these are the Hahn implants. you see the configuration of the fins or the threads in the X-ray, and the configuration of the top of the implant, the collar, or the neck of the implant, if you wish. And then we have the finished crowns. Now today, I had my own in-office laboratory for 30 years. Those days are over of having a technician that waxes and casts, and we have ceramic metal crowns. Today, it's all, we use custom abutments, or if we're doing screw retained, but everything is all ceramic. Most of it's done CAD/CAM, robotics, and the cost of setting something like that up would be totally prohibitive to have in your own lab. So things have changed. Implant dentistry is one of the fastest changing fields in medicine. It's not publicized, and Tim mentioned that early on about the changes and the advancements and getting involved in these things. And that's what's exciting. I'm not doing the same thing this year exactly that I did last year. We're always doing new things. An example is custom abutments and all ceramic crowns. So again, we want to just talk a little bit about the implant itself. The implant that I developed is called the Hahn implant, and we see the picture here. We have diameters 3.0, 3.5, 4.3, 5, and a 7.0. This implant is based on over 40 years of experience of placing implants. Tim talked about immediate extraction replacement. It's kind of one of my favorite things to do. With a thread pattern, we can keep it against the palatal wall. So we keep the implant off the buccal wall. The implant, if you have an implant that is in apposition to the facial plate, you have a chance to losing that bone, what we call an avascular necrosis because of blood supply. So we want a space between the facial of the implant and the facial bone. And Tim talked about some ways to also graft that space if it's big. But the initial stability, even though you have a space between the facial wall and the bone, with the initial stability of this implant, you can achieve 35 to almost up to 50 Newton stability and offer patients one stage. Sometimes we can place a temporary abutment and a provisional crown out of occlusion and using a good provisional cement. So I don't have time to get into the exact configuration. I did keep the machine collar, and there again, that's based on implants that we placed, and we looked at the X-ray over a period of 35 years. Now, a lot of these patients are still in my practice, and we get to see what's happening. And we have the micro threads at the top to give additional surface retention, but also channels to trap blood. So we give blood to the thin cortical walls of the sockets, or if you're, as we go to the crest of the bone, where it may narrow some. So again, we're providing nutrients of the blood to that cortical bone. So anyhow, that pretty much concludes what I have to say. We can see some examples. Again, I do a presentation called the emergency implant, and there's so many opportunities. Patients that call our office that broke an anterior tooth, a root, most of the time it's a root canal tooth, as you saw in Dr. Kosinski's presentation, and we can offer this patient to walk out immediately with a provisional tooth so that they can go about their job, meet the public, or have a social engagement, and it's marketing. And we call it the wow effect. We can take the tooth out, extract the root, and as you saw, Dr. Kosinski showed you atraumatic extractions. And that's the most important part. The most important step in immediate placement is the extraction, preserving the bone. And again, with this design of this implant, we can keep it against the palatal bone or the lingual bone, keep it stable. And for beginners, We designed a kit that basically is left to right, step by step. If you're doing, for instance, a 10 4.3, it would start with drill 1, 2, and go to drill number 3, the magenta color, and drill number 4, which is the yellow. And then if the bone is dense, we can use a thread former. One thing about the design of the threads of the Hahn implant, we can actually put these in narrow bone and expand the bone as we're placing it. And there again, that requires some experience, and you feel the viscoelasticity of bone. Okay, next. Next picture. So we see the tapered drills. Again, these are quad spade drills, and Tim mentioned some different grafting materials. One of the good features of these drills, it collects bone. You're collecting patient's autogenous bone. And autogenous bone is very good. One, it's osteoinductive, and number two, it's free. The patient gave it to you. So you can see again, putting in a 4.3, the steps. The drill on the far left, or the instrument on the left, is a drill extension. So if you have to get in between the teeth, for instance, incisors, where the crowns are longer, your handpiece is going to be hitting the incisal edges, then we can use the extension. So we have, again, the 2-millimeter twist drill with lines according to the lengths of the implants, 8, 10, 11 and a half, 13, and 16. And then in dense bone, we have a thread former, which is on the right with the yellow band that has, looks like threads on it. And then we have the carrier for the implants, the insertion instruments. There's a long and a short. That's a long that you see in the picture. Next. So again, I've tried to design this system, the things that happen in my practice every day. My practice is strictly designed for implants. We do the implant placement in the morning and the prosthetics in the afternoon. So basically, we're the master of our domain. It's the same kind of practice that Dr. Kosinski has. So I try to design things that make life easier. Most healing abutments are parallel walled, so when you suture, the tissue has a tendency to come over it. But design these healing abutments almost hourglass-like, and also with an emergence profile, thinking of the aesthetics of the soft tissue and keeping the tissue stable. And again, matching it with impression copings. I use closed tray. So these are closed tray copings with deep grooves, so we have a good positive seat into the elastic impression material. Okay, next. So again, in summary, we've placed and restored over 500 Hahn implants in compromised bone situations. We've done sinus bumps, bone expansion, implants with grafting at the same time, and with a high degree of success and predictability. So anyhow, I urge all of you that are not placing implants to jump in the pool, get lined up in some courses. And again, Dr. Kosinski's course is a great course to start. We didn't have anything like that when we started. The instructor was like 6 weeks ahead of us in experience, so it was the trial and error days. But that's over. Implant dentistry is a predictable science. So good evening and thanks for joining. And if you have any questions, why, we're here to answer.
All right, thanks, Dr. Hahn and Dr. Kosinski. This is Kurt Lawler from Golden Dental Solutions. I'm going to keep my portion just a few seconds so we can get into the questions that people have submitted. We probably forgot to mention this at the beginning of the webinar, but anybody that has questions, you can type them in during the presentation. It's probably a little bit late for that, but we do have a handful to get through. But as I'm just finishing up my portion, and if you have any questions you'd like to ask Dr. Hahn or Dr. Kosinski or myself, please go ahead and just type them in there on your screen. Over to the right, you should have a menu bar where you can go ahead and put in your questions. So I'm going to keep my portion pretty short. I wanted to just mention that here at Golden Dental Solutions, we like to share the clinical content. We work with great doctors like Dr. Hahn and Dr. Kosinski that produce great photography and great dentistry that they like to share with others. And one of the things that we've recently done on our webpage is if anybody that's on the webinar this evening would like to receive like a weekly case, we do send out a case like usually every Friday that outlines rapid step-by-step photography. We allow you to ask questions that are usually answered by somebody here in our office or Dr. Kosinski. And I just wanted to mention this quickly. It's a great opportunity to see content every week, stay engaged with what we're doing here. And you can sign up, it's free of course, on our website if you'd like to get that email each week. I just wanted to mention that. That's something new we've been doing here for the last few weeks, and it's been pretty successful so far. Lastly here, if I can get my slide to come up, I wanted to provide a promotional offer. So we obviously know your time is valuable. Whenever we do these webinars, we normally will provide a discount on any of our products. If anybody found anything interesting this evening, whether it's the physics forceps or the grafting materials or the WAMKey or the VibraJect, we sell a bunch of unique and different clinical products. We provide a promotional code, which in this case for the webinar this evening is just TOOTH, so it's TOOTH. We provide a 15% off discount on any of our products. I think if you look at our bone prices, you'll find that they're actually already quite low. And then if you add on to the 15% discount, it's actually a really great pricing if anybody wanted to try the osteogen plugs or the allografts or the particulates or anything that we do sell. We only sell direct. We don't sell through the dealers. Physicsforceps.com is where any information and further videos and information on the products can be found. Otherwise, our phone number here in the office is 877-987-2284. And then last but not least, we do a 15% off discount, which is actually quite good. It's actually even better than the trade shows and other promotions we do during the year. We do it for a quick special, so it's a 24-hour special. If anybody wants to take advantage of it, it's good through tomorrow. So again, it's promotional code TOOTH, and I'll go ahead now and get to some of the questions here for Dr. Kosinski to provide his comments. So Tim, I guess somebody had a question about the WAMKey system. I guess they wanted to know why there's, or I guess they asked if there's one key, two keys. It looks like they're asking why is there maybe more than one key, and I guess generally, which one do you use the most in your experience? Tim, are you there? Are you muted? We'll bear with us, everybody here. We'll get Tim on.
All right, just grabbing a sandwich, Kurt. Just grabbing a sandwich. So there's three keys with the WAMKey, and everybody out there, what I really love about Golden Dental Solutions and Kurt and Dr. Golden is they're a family-owned business here in Detroit, and they back up their products. And Kurt, I don't want to speak for you, but you allow doctors to actually use the products for a period of time, and if they didn't like them for some reason, they could return them. I don't think very many doctors return anything, but it's a product that anything that makes my job easier, that saves my hands and my body and my back, are important to me. But going back to the WAMKey, it's a set of three instruments, a small, a medium, and a large head, little ball on the end, and it's simply for different size teeth. Sometimes you'll make an opening and you may make it a little bit larger, so you'll use the next larger key. So it's a set of three, and you need all three to be able to simply rotate your wrist and remove that crown. It saves a lot of time, and you know what, even more importantly, burrs are expensive, and we all go through porcelain, and especially Bruxer or zirconia crowns, we go through those burrs, and they're very expensive. So making a small opening is a lot more effective than cutting an entire crown off. and your time is so valuable. So it's a set of three, and you need all three.
Okay, thanks, Tim. I guess the next one is you usually get this on pricing, for patients and grafting. I guess the question though is, graft products, have different prices, different costs to you, the dentist. Do you change the pricing for your patients based on the product, or do you just have a set fee for a graft?
Great question. Great question. First and foremost, it's important to realize that all allograft materials, regardless of where you get it, is basically from one of three sites in North America. So it's very, very well controlled today. Now, to make things simple, in my practice, no. A graft is a graft. A membrane is a membrane. The amount is really irrelevant to me. I think that the hard thing for doctors is there's cost involved with the product, and what do you charge the patient? And if you overcharge as general dentists, the patients are going to balk because your dental insurance isn't going to cover it. So I think it's important for doctors to understand what their overhead is. If they get a good product at a fair price, I know we went very fast today, and hopefully we'll see some of you in our courses. And Kurt, I don't know if you're going to discuss that. We do a extraction course at the University of Detroit. It's a one-day program on a Saturday. And then Dr. Aaron Azarian and I do a two-day grafting program, a day of lecture in the city, and then we go to our dental school, and every doctor gets to work with at least three different materials, three different grafting materials, and two different membranes. And so we can teach you on live patients how to repair facial wall defects, etc. So anyways, getting back to your question, we just try not to overcharge for the procedure. And if your staff believes in it and it's an effective way of maintaining bone, patients just don't balk at it. I think they realize the importance of this technology. But you have to believe it, and you have to feel confident with it. Very, very important, Kurt, and for those of you who are listening, the only way you're going to do this is if the results are predictable. Because if you're not getting predictable results, you and your staff are not going to believe it, and you're going to stop doing the procedure. And if I've left you with anything tonight, I hope that I left you with the understanding that you are certainly capable of getting predictable results like I am. All of you out there, you just have to follow the rules.
Okay, great. I think you probably touched on this, but I guess just to clarify, somebody asked whether you elevate in advance when you use the physics forceps, and I think the answer is no, but I'll let you answer that.
Yeah, I've seen doctors do that, and I haven't found the need to it. In the past when we did an extraction, we brought a big bin full of different instruments to try to get a tooth out. And now, if I'm taking out a lower tooth, they bring me one forceps. If I'm doing an upper right tooth, they bring me the upper right forceps. Me personally, do not elevate. The only teeth that maybe we'll try is sometimes a maxillary anterior teeth, like cuspid teeth, where I showed you the bone can be very, very thin. I may try to elevate that or luxate that a little bit to get some movement, if I try to maintain that facial plate of bone, because it can be very, very difficult when the bone is very thin. But routinely, I go right to the instrument, to be honest with you.
Okay, great. I guess one more WAMKey question that came in. Looks like, will it work if it's a ceramic crown that's resin bonded? Tim, I don't know if you want to answer that one.
Yeah, it does. Depending on the bonding strength and things like that, because it really is leverage in doing it, and it just saves so much time and energy. If the resin can be broken off of the porcelain crown, then yes, it'll work very, very well.
Yeah, and just to expand on that, I guess the case is, it's not going to work well on a lower anterior tooth. I mean, the teeth are obviously just too small. But you can find, I think it's on our website or even on Dental Advisor's website, they did a study in the last couple of years on like 300 different types of crowns. And I believe it was either 90 or 92% effective, they found, the WAMKey system. So it does work. People always ask that question on the different types of cements and things that are on the market nowadays. But a lot of times too, it's usually an older crown that's being removed anyways. WAMKey for sure is a more efficient solution to that, to removing a crown. But if it doesn't work, you're going to do what you did anyways, which is cut it off. All right. Somebody else asked about whether the bumper on the physics forceps minimizes bruising, or is it just they mentioned something about, is that just your fulcrum or your pivot point? I guess if you just want to clarify that again.
Yeah, oftentimes I'll use the instrument without the bumper guard, the silicone. The bumper is simply a fulcrum, and it's a very hard concept to understand. I wish you guys didn't call it a forceps. I wish you called it something else, because the biggest problem we have is we all have muscle memory, and we want to take those handles and we want to squeeze them. And that's not how the instrument works at all. So there is a learning curve in using it. And I would suggest, watch some of the videos that we've done on YouTube that you can find on Golden Dental Solutions site. I guess goldendentalsolutions.com. And no, it's intended to be the center of rotation of the instrument. It's not really the working end of the instrument at all. So if you are getting bruising, and I've heard it, I've talked to doctors, it's just because you're squeezing the instrument too much.
All right. With the physics forceps on an upper cuspid tooth, sometimes, if based on the angulation of the root, do you ever place the bumper at a slightly, I guess they're asking, is it like a distal placement of the root to get better lift or leverage with the instrument? I guess they're asking whether the bumper is always placed in the same position on a cuspid, or do you sometimes angle it a little bit differently?
Wow, that is a amazing question. That's a great question. No, so think it's all engineering, and I know we're not engineers, but the tooth has to follow the path of least resistance. And cuspid teeth are oftentimes tilted, right, or angled a certain way, and so you have to hold the instrument so that the forces are put along the long axis of the entire root. So if you have a distal inclination of the root, the apices of the root, the bumper has to be placed more distally so that the tooth can come out easily. If you don't follow that, and if you're at a funny angle, that's where facial plate of bone will be broken. Great question. Wow, that was a good one.
Okay, somebody asks, upper molars can have long, thin roots, curved. Do you section upper molars?
Wow, another great question. No, mandibular molars, I almost always section. Maxillary molars, it's medullary bone, it's softer bone. Very, very, very rarely would I section an upper molar. The bone is soft enough and the instrument is such that I can remove the tooth simply using the physics forceps very, very predictably.
Okay, question on the osteogen. Do you wet it or do you place it dry?
I put it dry in a bloody socket, and it just kind of forms right to the socket walls. It's pretty cool material.
All right, and then just one more question on that is it, I guess they're asking, do you cut it to size? I guess I'm elaborating the question here because I know there's two different sizes of it, but I guess the question is
you're overfilling the socket, so a socket is wider at the crest than it is at the apex. So if it's a molar tooth or a wide, sometimes I do cut it, sometimes I don't. Yeah, you can cut it in half. It's easily cut with sharp scissors.
Okay, and just to elaborate on that, there's a large size and a slim size,
Right.
obviously based on the shape of the socket, what makes the most sense. But the large can be cut and rolled to basically turn it into two slims.
Right.
All right. What else here? I guess I'm trying to figure out how to answer this one. For if somebody was having some issues, I guess, with learning the technique, I guess every once in a while we'll get somebody that they still have in the mental mind frame of wanting to squeeze the instrument or do it a conventional type forceps. I guess, Tim, in your view, what are the most likely reasons why somebody may have some bruising or not getting the tooth to move. If for the couple people are on the line that are saying sometimes they wish the product worked a little bit better for them sometimes.
So, number one, I think there is a learning curve, as I mentioned. I think that you have to realize, and I've struggled with trying to explain it in words. The tension or pressure is simply put on the lingual or palatal aspect. And to do that, you have to hold the instrument such that you're not squeezing the bumper and beaks together. It's not like a conventional forceps at all. And that's our muscle memory is forcing us to do oftentimes, including me. And so when you realize that the technique is such that you have to follow the arc of rotation of the uniquely designed instrument, then you don't have that issue. And then it kind of becomes a simple thing to remove teeth. If you're bruising and you're continually breaking facial plate of bone, it's because you're squeezing the instrument. As I mentioned, we do have a one-day program at the University of Detroit Mercy School of Dentistry. And Kurt, what do we see, like 80, 85 patients? Everybody takes out a lot of teeth during those courses. So I think it's worth to spend a day with us, with Dr. Golden and Dr. Nazarian and some of the oral surgeons and myself in learning the technique and practicing on live patients. I think is a wonderful way to learn.
Okay, yeah, thanks. Just to expand upon that a little bit, some people will ask, what kind of training comes with the product? Of course, it comes with a great DVD. We update it about every year or two with new cases, new tips. Most people do get it right away, but as Tim mentioned, if anybody's struggling out there, the live patient course is obviously a great opportunity to perfect the technique. And then there's also some people that just like to try it first in advance on live patients. One thing I'll mention, the course is open to any dentist in the U.S. You obviously don't have to be licensed in Michigan. We do it at the university, which is a teaching facility. And then it's also open to anybody in Canada. So we get a lot of folks from Toronto and elsewhere here around Detroit to join us at our programs. You'll find all that information on our website under the education courses at the top. It says education courses, and you can review a little more information about the two programs that we do offer here with Dr. Kosinski as one of our lecturing doctors. I guess I'll probably wrap it up here. I know we went a little bit over, and I appreciate everybody's time. Again, we're available here. The phone number is still on the screen. If anybody has any questions this week on anything we discussed, or if anybody wants to ask Dr. Kosinski or Dr. Hahn anything directly, we're more than happy to pass it along. And I guess I'd just like to thank everybody for joining the webinar this evening and investing your time with us. It was a pleasure to have Dr. Hahn and Dr. Kosinski with us this evening, and we really appreciate it. And I hope everybody can join us again in the near future for our next webinar. Good night, everybody.